In this lecture, I will attempt to summarize cardiology biomarkers past, present, and future. What exactly are biomarkers? They are proteins or other macromolecules that indicate a biological process. Thus, in various pathological processes, if their serum levels increase, it helps in diagnosis, prognosis, or therapeutic decisions. What could an ideal cardiac biomarker look like? First, it should be specific, originating solely from the heart muscle and without false positives. It should also be sensitive, detect the slightest damage, and not yield false negatives. It should have prognostic value. Its plasma levels should correlate with the extent of damage, rise quickly after plaque rupture, remain elevated for a while, and, most importantly, be easy to measure with a rapid test. What insights can we gain from cardiac injury markers? First, we can confirm or rule out an acute infarction. We can also verify the presence of a previous infarction that occurred several days earlier. These markers help monitor recurrent reinfarctions and can indicate the success of thrombolytic therapy. What biochemical markers can indicate myocardial ischemia or necrosis? Biochemical markers that can indicate myocardial ischemia or necrosis include several key cardiac enzymes. The most commonly assessed markers are total creatine kinase and its isoforms measured for activity and quantity. Other important indicators include aspartate aminotransferase, AST, lactate dehydrogenase, LDH, and proteins such as glycogen phosphorylase BB, GPBB, troponin, myoglobin, ischemia-modified albumin, IMA, and heart-type fatty acid-binding protein, HFABP. Messenger vesicles and microvesicles can also act as biomarkers for these conditions. These markers can be categorized by their usage status. Some are older and were introduced early in clinical practice, but are now less frequently used due to technological advancements, although they may still occasionally appear in clinical settings. In clinical practice, common biomarkers include lactate dehydrogenase enzyme, myosin light chain, aspartate transaminase, and creatine kinase's total amount and activity. The standard biomarkers currently in use are troponin T, troponin I, and CKMB, which are measured in terms of their activity and quantity, along with myoglobin. Several biomarkers are currently being developed and may be adopted in the future. These biomarkers include microribonucleotide acids, heart-type fatty acid-binding protein, ischemia-modified albumin, glycogen phosphorylase BB, copeptin, and B-type natriuretic peptide, BNP, growth differentiation factor 15, GDF15, and pregnancy-associated plasma protein A, PAPPA, could also see broader use moving forward. For laboratory testing, samples are typically collected from serum. If serum is not available, heparin-treated plasma is acceptable. Venous or whole venous blood is usually suitable for detecting rapid troponins. A crude saliva sample may also be appropriate for detecting these enzymes or materials. We typically collect samples multiple times, at hospitalization, 2 to 4 hours later, 6 to 8 hours later, and 12 hours later. These are the standard sampling intervals. The history of cardiac biomarkers shows significant advancements in the 1950s, using serum aminotransferases to diagnose acute myocardial infarction. In the 1960s, lactate dehydrogenase, LDH, and creatine kinase, CK, were introduced as biomarkers. By the early 1970s, isoforms of creatine kinase were discovered, and in 1972 to 1973, cardiac-specific isoforms were identified. Research revealed that creatine kinase and LDH isoforms could be separated by electrophoresis due to their different charges, which were subsequently detected using immunoassays, including radioimmunoassay, RIA. In the mid to late 1970s, the MB isoform of creatine kinase and myoglobin were introduced through radioimmunoassay, RIA techniques. Quantification methods for these biomarkers emerged in the mid-1980s. In the 1990s, cardiac-specific troponins T and I were introduced. By the 2000s, the ratio of total troponin to troponin I was used for risk estimation, and standardization of these biomarkers was established in the early 2000s. The timing of sample collection relative to the infarction significantly influences the diagnostic value. Diagnosis can be more difficult if the patient arrives too early. Early arrival might mean biomarker levels haven't risen yet, while late arrival may coincide with already decreasing concentrations. Therefore, understanding the kinetics of different biomarkers is essential. Some markers rise quickly but decline soon after. Others peak later and persist longer. This variation is also influenced by the type of assay used, whether it detects enzymatic activity or immunological quantity, and whether high sensitivity methods are applied. Let us first summarize the biomarkers of necrosis that have been used in the past and are still utilized in some cases. One of the primary biomarkers is lactate dehydrogenase, LDH, which is found in nearly all cells including cardiac muscle cells, vascular muscle cells, liver, kidney, platelets, and red blood cells. LDH has 5 main isoenzymes, each consisting of 4 subunits built up from 2 kinds of forms. For instance, LDH1 is characterized by having 4 H subunits, while LDH5 is composed of 4 M subunits. In the context of myocardial infarction, isoforms 1 and 2 of lactate dehydrogenase are elevated, with LDH1 being a more sensitive indicator of myocardial infarction. The isoforms 4 and 5 are primarily associated with liver and skeletal muscle injuries. Additionally, mixed isoforms 2, 3, and 4, which contain both H and M subunits, are most characteristic of platelets in the lymphatic system. Total LDH activity increases relatively late, typically around 1 to 2 days after an event. It peaks approximately 3 hours after the initial rise and normalizes after about 2 weeks. The principal isoenzyme that rises is LDH1, which may increase slightly faster than LDH2, but normalizes after 2 weeks. The rise in LDH1 and the increase in the ratio of LDH1 to LDH2 are sensitive indicators, with sensitivity and specificity reaching as high as 75 to 90%. Today, LDH testing is utilized when a patient presents late to the doctor after experiencing chest pain. In this scenario, we can determine whether an infarction causes the chest pain. Necrosis enzymes are called myosin light chains, which are produced in myocardial-specific muscle blood and the slow-twitch muscle. Aspartate aminotransferase is found in several cells, including skeletal muscle, liver, red blood cells, and heart muscle. Its half-life is relatively long, estimated at 10 days. It has 2 isoforms, mitochondrial and cytoplasmic. The mitochondrial starts to rise after 6 to 8 hours, peaks after 18 to 24 hours, and normalizes after 4 to 5 days. Currently, the most used biomarkers are creatinine kinase, an enzyme, cardiac troponins, and myoglobin. These will be discussed next. Full activity of creatinine kinase and the role of its isoenzymes. Creatinine kinase regulates the production and use of high-energy phosphates, ATP phosphocreatine, in contractile tissues. Cytosolic creatinine kinase is a dimer consisting of an M and a B subunit. It has 3 main isoenzymes, MM, MB, and BB. MM is found in skeletal muscle, MB in cardiac muscle, and BB in the brain. As can be seen here, the skeletal muscle has an activity of about 2,500 units per gram. It is much lower in the myocardium, about 470 units per gram, and in the brain it is 50 units per gram of tissue. There is also an elevated occurrence in the small intestine, tongue, diaphragm, uterus, and prostate. The tissue and plasma ratio is high in skeletal muscle and cardiac muscle. Total creatinine levels are no longer used to diagnose infarction. As I mentioned, some isoforms, such as MM, are found in skeletal muscle, but small amounts are also found in cardiac muscle. MB is predominantly found in the myocardium and only in small quantities in the vascular muscle. The BB isoform is found in the brain, large intestine, ileum, stomach, and bladder. A second rise in the plasma enzyme level indicates reinfarction development. No significant creatine kinase elevation exists in stable angina when no infarction exists. Serial measurement is more informative than determination by a single value. The MB isoenzyme of creatinine kinase is the most commonly used to diagnose myocardial infarction. It is interesting to note that in left ventricular hypertrophy and coronary artery disease, total CK activity may be reduced. However, CKMB content and activity also increases. Creatinine concentration in the blood, on the other hand, decreases. Without coronary artery disease and left ventricular hypertrophy, creatinine kinase activity is usually normal, but CKMB activity and amount are also higher. Similarly, creatinine will be reduced. In healthy individuals with neither left ventricular hypertrophy nor cardiovascular insufficiency, virtually no CKMB activity is observed. Elevated and persistently elevated CKMB levels in patients with cardiovascular disease show excellent myocardial specificity. Skeletal muscle injury may alter creatinine kinase MB activity or mass. Total creatinine kinase may increase up to 7-fold per gram in the presence of muscle injury. CKMB is released in significant amounts at the site of injury. Since the skeletal muscle mass is about 100 times that of the myocardium, the small amount of MB from skeletal muscle may affect the value. The creatinine kinase MB index is the creatinine kinase MB activity divided by the total creatine kinase activity. Its value is approximately 1.075. If this value rises above 3, it usually indicates myocardial damage. Skeletal muscle-derived CKMB may also distort the CKMB index by suppressing the test CKMB specificity. The CK measurement is only accepted as a diagnostic marker if a troponin test is unavailable. Its advantage over tropine is that it is rapidly cleared, making it suitable for the detection of reinfarction. Continuing with MB isoforms, a prostate translational modification occurs after tissue CKMB release. The C-terminal lysine amino acid is degraded by carboxypeptidase in the blood. Consequently, 2 forms are found in the circulation. The 2 forms have different charges and can therefore be detected by LFO. The tissue form is MB2, while the modified form is MB1. Typically, the ratio of these two is about 1, and the total activity is less than 1.5 units per liter. The MB2 isoform appears about 1 to 1.5 hours after injury. It peaks at 4 to 8 hours. CKMB will increase to a value greater than 2.5 units per liter in pathological conditions. At the same time, CKMB2/CKMB1 is more than 1.5. Its diagnostic value within 6 hours of myocardial infarction is high. Its sensitivity is 95.7%, while its specificity is 93.8%. The subunits of troponins are T, I, and C. Troponin T is linked to tropomyosin. Troponin I inhibits the interaction of actin and myosin, and troponin C is the calcium-binding subunit. During muscle contraction, calcium flows into cells and binds to troponin C. This induces a structural change in tropomyosin. This frees the binding sites of actin and allows cross-linking and muscle contraction. The amino acid troponin C sequence is identical in skeletal muscle and myocardium, and therefore cannot be used as a specific marker for both cardiac myocytes. T and I are different forms in myocardium and skeletal muscle, encoded by separate genes and have distinct amino acid sequences. They originate exclusively from the myocardium. Therefore, the presence of troponin T and I in the blood is cardiospecific. A highly specific marker of myocardial damage, rare analytical false positive results in occurrence, especially in the context of renal failure, for example. Troponin release and its forms. Troponin TIC complex is released from damaged cardiomyocytes in different molecular forms. First, the whole complex, TIC, is released from the damaged cardiomyocytes. Then the IC complex and free T can be found in the blood. Later, the free subunits and fragments of both immunoreactive and non-immunoreactive forms occur. Small amounts of troponin I and T are also found in the cytoplasm. Troponin I can exist in oxidized, reduced, and phosphorylated forms. They are not early necrotic markers, but their diagnostic sensitivity and specificity are high. It is particularly useful to measure them at the first examination, then 6 to 9 hours later, or 12 to 24 hours later, if there is high clinical suspicion and the previous values have not increased significantly. The blood concentration may remain permanently elevated. Its release may show individual differences. Therefore, the presence of an infarction cannot be predicted from a single measurement alone at the beginning. It is less suitable for estimating the extent of reocclusion or infarction since it subsides late. They can be used for heart-specific risk assessment. However, they can be detected up to 2 weeks after the infarction. The tissue concentration of troponin is usually 13 to 15 times higher than that of CKMB. Most troponins are bound to the contractile apparatus. The cytoplasmic pool is about the same as that of creatine kinase, MB. It persists in plasma for a long time. In the case of microinfarctions, both troponin and CKMB are elevated. Both are strong predictors of subsequent acute coronary events, even without CKMB or ST segment changes. It has significant therapeutic benefits for initiating antithrombotic therapy and performing an early percutaneous coronary intervention, PCI. Its sensitivity in initial measurements is usually 51% for troponin T and 66% for troponin I. Values between 0 and 4 hours increase from 51% to 94% for troponin T, from 66% to 100% for troponin I. The specificity is approximately 89 to 98%. Qualitative versus quantitative troponin tests. Qualitative troponin measurements, which are usually performed as point-of-care tests, POCT, and quantitative laboratory measurements can show a difference of up to 30 times, which is why these POCT measurements are not suitable, especially in the hands of those who are not experienced in using them. The purpose of qualitative tests is rapid screening, while quantitative tests are used to follow dynamic changes, risk classification, monitor reperfusion, and estimate prognosis. Myoglobin is a heme-containing oxygen-binding protein released from the cytoplasm of skeletal and cardiac muscle in the event of injury. The tissue-to-plasma ratio is exceptionally high. It appears rapidly in the blood. It is the earliest routine marker to appear. The kidneys rapidly clear it after necrosis, so it is unsuitable as a long-term marker. Its level varies depending on gender, age, and physical activity. It is more sensitive than creatine kinase and its isoforms. However, if the patient is hospitalized 10 to 12 hours after the complaint, CKMB is a more reliable marker. It is not cardiac specific, so it is worth using it with other markers. It has a high negative predictive value. Normal levels can effectively rule out myocardial necrosis. Its specificity is approximately 96%. It can also be elevated in skeletal muscle diseases and chronic renal failure. The following table shows the changes in these markers over time. Myoglobin appears as early as possible and usually subsides within a day. The next, which are relatively fast, are troponins and creatinine kinases. Creatine kinases drop after only 2 days, while troponins remain at higher levels for 10 to 14 days. LDH can be measured for several weeks. Among the new markers that should be highlighted is the one that will most likely be suitable for introduction in the diagnosis of myocardial necrosis within a few years. Perhaps the first is cardiac-type fatty acid binding protein, HFABP. It is found in large quantities in the cytoplasm of striated heart and skeletal muscles. It specifically and reversibly binds long-chain fatty acids. The same isoform is present in both heart and skeletal muscle. However, the concentration measured in skeletal muscle is only 10 to 30% of the amount calculated in the heart muscle. It has a high tissue-to-plasma ratio, making it suitable as an early marker. It can be measured as early as 30 minutes after damage, reaches its peak value at 6 to 8 hours, and then drops off nicely within 1 to 2 days, returning to normal values. When combined with myoglobin, diagnostic accuracy can be increased. The glycogen phosphorylase BB isoenzyme, GPBB, is one of 3 isoforms and is primarily found in the heart and brain. However, because of the blood-brain barrier, GPBB levels measured in the blood mainly indicate their origin from the heart. As a result, GPBB may serve as an early marker for myocardial necrosis. The increase can be measured as early as the first hour. It reaches its peak value 1 to 3 hours after ischemia. It is a very sensitive marker. Its sensitivity exceeds that of myoglobin, creatine kinase, and cardiac-specific troponin T. Copeptin is the C-terminal portion of provasopressin, which is co-secreted with vasopressin. It is elevated within minutes in acute myocardial infarction. Combined with troponin I, it helps to rule out acute myocardial infarction quickly, so it can be decided initially whether the person has it or not. Carbonic anhydrase 3, CKE, a cytosolic protein, is found almost exclusively in type 1 slow-twitch skeletal muscle. It is not found in cardiac muscle. The ratio of myoglobin to this carbonic anhydrase is 3:1 in skeletal muscle injury. In acute myocardial infarction, myoglobin is significantly increased, but since the amount of carbonic anhydrase 3 does not change, this ratio will be much higher. Their combined examination may improve the specificity of myoglobin and the early detection of myocardial infarction. After intense physical exertion in healthy individuals, both myoglobin and carbonic anhydrase 3 may increase. It may also be elevated in neuromuscular diseases. Myoglobin is significantly increased in myocardial infarction, while carbonic anhydrase is not. The change in the ratio is therefore of diagnostic significance. Ischemia-modified albumin is still under development, which reduces the cobalt binding capacity of albumin due to oxidative damage to the N-terminal part by free radicals. A cobalt albumin binding test can detect elevation of IMA. During the modification, free radicals, such as hydroxyl radicals, degrade the terminal protein, thereby reducing metal binding. It increases within minutes during ischemia, peaks at 2 to 4 hours, remains elevated for 6 to 12 hours, and normalizes within 24 hours. It is sensitive to ischemia, but not to necrosis. It can also increase after prolonged physical exertion, for example, after marathon running, but normalizes within 24 hours. It can also increase in connection with events of non-muscle origin, for example, diabetic ketoacidosis, sepsis, chronic renal failure, liver diseases, and tumors. The release of endogenous lactate can also inhibit the test. Its application is therefore limited. Perhaps the most promising are these microRNAs, which are small, non-coding RNA molecules, consisting of approximately 22 nucleotides. More than 3,000 genes in the human genome encode microRNAs. Their function is to regulate gene expression by inhibiting or degrading messenger RNA. Their effect is to cleave or destabilize messenger RNA by shortening the polyadenosine tail, thereby reducing translation efficiency. Heart muscle damage and cell death activate many gene processes, so changes in the level of circulating microRNAs can be seen in the first hour. They are stably present in the blood. They are often tissue and disease-specific and have high sensitivity and specificity. For example, among the microRNAs diagnosed, MIR1, MIR133, and MIR499 are perhaps the most prominent in myocardial infarction. MIR499 has slower kinetics and is more beneficial for later diagnosis when troponin has already returned to normal. MIR208 cannot be detected in the blood of healthy or stable coronary artery disease patients. However, it can be detected within 4 hours after infarction. Troponin I was only positive in 85% of cases, while MIR205 was much more sensitive in this case. Some microRNAs, such as MIR122 and MIR375, may decrease during infarction. In the future, using microRNAs together with troponin, I will be an ideal diagnostic marker. Saliva samples are an excellent method for diagnosing myocardial infarction, as they are simple, fast, and non-invasive. The whole saliva contains components from serum, gingival fluid, and salivary transudate. Salivary markers such as myeloperoxidase, C-reactive protein, myoglobin, creatine kinase MB, and cardiac-specific troponins can be detected in the case of myocardial infarction. Saliva can be an alternative to serum in the diagnosis of myocardial infarction. Recent developments, such as using various nanochips and mucous membrane wands with ECG, have allowed for the detection of infarction within minutes. In the following, I would like to say a few words about biomarkers used in heart failure. Heart failure is not simply the result of cardiac overload or damage, but rather a complex pathophysiological process that develops through the interaction of genetic, neurohormonal, inflammatory, and biochemical factors. Biomarkers, enzymes, hormones, and proteins play a significant role in diagnosing heart failure, risk assessment, and treatment monitoring. What biomarkers can we use in heart failure? How can we group these biomarkers? First, I would highlight biomarkers of inflammation, oxidative stress, and extracellular matrix transformation. In addition, neurohormones, biomarkers indicating monocyte injury, markers of myocyte stress response, or new ones that are not yet fully understood and are under research should also be mentioned. Among the inflammatory biomarkers, I would first highlight C-reactive protein. This is a non-specific inflammatory marker, and elevated levels are associated with the severity and prognosis of heart failure. It can also have a direct effect on endothelial function. Tumor necrosis factor alpha and interleukins, such as IL-1, IL-6, and IL-18 are pro-inflammatory cytokines that directly damage the function of the heart muscle. TNF-alpha inhibition did not bring clinical improvement, so it does not show a correlation with the state of heart failure. High levels of the apoptosis mediator FAS-APO1 are a poor prognostic marker in the case of heart failure. Oxidative stress biomarkers. Oxidative stress and nitro-oxidative damage play an essential role in the progression of heart failure, such as myeloperoxidase, malondialdehyde, and isoprostanes, which are inducers of free radical formation, may correlate with disease severity. Uric acid, which is not a very specific but easily measured marker, may also be a marker of oxidative parameters. The remodeling of the extracellular matrix and the structural transformation of the heart chamber are constantly taking place. Matrix metalloproteases and their TIMP inhibitors play a significant role in this. They are the primary regulators of the breakdown and buildup of the extracellular matrix. Procollagen 1 and the 3 peptides are biomarkers of collagen synthesis. Their high levels indicate an unfavorable prognosis. Among the neurohormones, high levels of norepinephrine, renin, angiotensin, and aldosterone are associated with the severity of heart failure. Blocking these systems plays a key role in treatment. Endothelin is a vasoconstrictor and has a fibrotic effect. High levels may indicate a poor prognosis. Arginine and vasopressin cause water reabsorption and vasoconstriction. Their therapeutic use is still uncertain. Troponin I and T, as detailed above, are the classic markers of myocyte damage. Their high levels are also an unfavorable prognostic sign in heart failure. Other proteins, such as cardiac fatty acid binding protein and creatine kinase, MB fraction, may also be informative in diagnosing and predicting heart failure. Natriuretic B-type protein and its metabolite, NT-proBNP, are the best validated biomarkers for detecting myocyte stress. They are secreted in response to myocardial wall tension and are extremely useful in monitoring diagnosis, prognosis, and therapy. Their elevated levels are associated with mortality. Proadrenomedulin, MR-ProADB, and ST2 are newer markers that, when combined with NT-proBNP, may enhance its prognostic value. Biology of MNP and MP-proBNP. B-type natriuretic protein is a 32 amino acid peptide released mainly from left ventricular and ventricular myocytes in response to mechanical stress. The cleavage of pro-BNP yields an active BNP and an inactive NT-proBNP. The levels of both are proportional to the severity of heart failure. BNP and NT-proBNP markers have been validated. They play a significant role in the assessment of acute dyspnea. Precursor pro-BNP, from which active BNP and inactive NT-proBNP are formed. They are used in the prognosis and risk classification of heart failure. Their application can be used to identify acute and chronic heart failure and to judge the length of hospitalization of patients. Limitations. False positive elevations can be detected in the presence of hypertension, anemia, hypoxia, age, female gender, sepsis, and renal failure. False negatives can be caused, for example, by obesity. Atrial natriuretic protein has a short half-life of 2 to 5 minutes. Therefore, it is unsuitable as a biomarker. MMR-pro-ANP, a stable precursor of ANP, may provide a more accurate prediction of acute heart failure, especially in obese or chronic renal failure patients. It is a good predictor of 90-day mortality. It has already been included in the recommendations of the European Society of Cardiology, but it has not replaced BNP or its metabolite, NT-proBNP. Among the newer markers are chromogranin A protein with adverse inotropic effects, Galton-3, a macrophage marker that can be associated with fibrosis and death, and osteoprotogerin, a member of the TNF receptor family that can predict left ventricular dysfunction. Adiponectin is high in cachectic patients and is a sign of an unfavorable prognosis. Another novel biomarker is growth differentiation factor 15, GDF15, a stress-induced cytokine belonging to the TGF-beta superfamily. It is expressed at low levels under normal conditions, but it increases in cellular damage, oxidative stress, inflammation, hypoxia, mechanical stress, and ischemia. It reflects the severity of myocardial damage. Its primary sources are cardiac myocytes, macrophages, adipose tissue, liver, kidney, and endothelium. Pregnancy-associated plasma protein A, PAPPA, is a metalloprotease that degrades IGF-binding protein 4, IGF-BP4, enhancing the biological activity of IGF-1, insulin-like growth factor 1. IGF-1 plays an essential role in cell proliferation, survival, and regeneration. Thus, PAPPA plays a key role in tissue remodeling, especially in the cardiovascular system. In patients with acute and chronic heart failure, PAPPA levels are elevated. This level is associated with the severity of the disease and a worse prognosis, including mortality and exacerbations requiring hospitalization. PAPA levels are particularly well correlated with left ventricular dysfunction and myocardial remodeling. PAPA may be helpful as a prognostic biomarker, as its level may be an independent predictor of mortality and severity of heart failure. Its combination with other markers, such as the inactive natriuretic protein, B, galectin-3, or ST2, may enhance its diagnostic and prognostic value. What are the future directions? The combined measurement of several biomarkers, such as BNP, troponin, and CRP, will offer a much more sensitive option for estimating risk. New proteomic methods will allow the identification of new biomarkers. The role of biomarker profiles in heart failure classification and targeted therapy will definitely increase. Thank you for your attention.